Hello and welcome to the first podcast, part 2. My name is Ishan,
And I'm Meg.
and we are extremely excited to be doing and sharing this medical information with our community.
So, over the past few months, we have, as many of you probably have, been quarantining due to the coronavirus pandemic. We were talking a couple of weeks ago about something we could do to become more aware about the global situation, and the idea of a podcast popped up and became extremely appealing, as we could become more educated ourselves as well as educate others in the process. We want this podcast, however, to not only focus on this pandemic. Our goal overall is to connect ideas that interest us with teens everywhere. And we don't only want to talk about the current situation, but other ideas as well. So if there are any specific topics that any of you would like to hear about in upcoming episodes, please let us know in the comments, or you can email it to us. Our email will be linked below.
Today, we're going to be talking about the current COVID-19 pandemic that has put America, as well as several other countries like Great Britain, in quarantine since the middle of March. We are joined today by Dr. Nina Phillip, who is the Vice President of Patient Care Services and the Chief Nursing Officer at Hoboken University Medical Center here in New Jersey.
So we did a little bit of research on the situation in the US before coming up with a couple of questions. So as we all know, the US is currently one of the hotspots of the pandemic. And the CDC in several reports have explained that a majority of US COVID cases have emerged from imported travelers, close contact with confirmed cases, and community cases with an unknown source. There have been approximately 1.81 million COVID cases, and there is currently no cure. However, several clinical trials are underway and being expedited to develop a vaccine. Dr. Anthony Fauci, the director of the NIAID and a scientist at the NIH, has explained hopes of a vaccine emerging in 12 to 18 months.
And without further ado, welcome Dr. Nina Phillip. Thank you for joining us today. It's so great to see you, and thank you for your time.
Thank you. It's such a great honor to be on, and so exciting to hear from young minds such as you to kind of further the knowledge about what's going to happen, and perhaps you can be the change agents in the future.
Thank you.
Thank you.
All right, and now time for some questions. Yay!
Hey.
All right, so the first question is, have you felt a sense of unity from the public when it comes to supporting healthcare workers?
Yes, I mean, we have been really blessed at Hoboken University Medical Center. We have been receiving, ever since the pandemic started, first of all, let me say, from a public health effort to have people quarantine themselves and take this seriously is perhaps one of the biggest gifts that, the public can do for healthcare workers and for the patients. So having quarantining yourself, sacrificing is perhaps one of the greatest gifts that perhaps you have given us. The second part is a lot of people, when they sit at home, do feel like they want to contribute. They want to make the situation better. They want to feel like they're part of a solution rather than a problem in itself. And so every day, ever since the pandemic, or like in the middle of a pandemic started, the community started to kind of come together, and they would call into the restaurants, realizing the restaurants also are being closed. They don't have a way of making money. So they're kind of fulfilling a little bit of economic piece, as well as also helping the nurses and the doctors who, of course, are tired. They perhaps can't eat or, kind of give nourishment. So part of, I guess from a cultural perspective, the way you can help is through food. So we've been getting a lot of food donations from the community, who perhaps call it into the restaurants, and the restaurants give it to us. Sometimes the restaurant gives us free. They have been giving a lot of gifts. You see innovation happening where people are using 3D printers to print perhaps, the face shields. So we've been getting a lot of donations on face shields, realizing we've had issues with the lack of personal protective equipment. We got donations from medical masks, of course. We've had other donations on cloth masks, just so they can, we feel protected. There's a lot of people that have gone over and beyond their prayers and vigils. We have a 7 p.m. clap out every day outside our hospital. The community comes out and claps us, recognizing. So it's been an amazing experience, just watching the fact that the community is coming together and helping us do what we need to do for our patients.
That's
So
so
we see it gives us a lot of help morally, emotionally, spiritually. It gives us a lot of support as we're out there.
That's really
I
nice.
think that's great, especially since it's like so many different aspects that people are helping in, whether it be moral support or emotional support or
Right.
tangible goods too. I think it really has brought a lot of people together.
Yes, yes.
Yeah.
And that's the strength of the community, I do have to say.
Definitely, definitely. So our second question is, what compared to other countries has the United States been doing differently to prevent further transmission of coronavirus?
So I think when this whole thing started, of course, there was a lot, and it depends on which spectrum of the political ideology you're sitting on as to how people feel about what the U.S. could have done better or different from the other countries. But overall, I think, I'm going to take the positive aspect of it is we, as far as testing and using a lot of resources, we are one of the greatest or richest countries in the world, perhaps using those resources to kind of help expedite testing, vaccine production, helping us in the hospital side to have those resources, on the acute care side to do much better with that, from the public health perspective as far as contact tracings are concerned, monitoring people. A lot of these needs resources, and perhaps as a country, I think that's what's great about the pieces of it. What perhaps we could have done better is we always tend to do better. If you sit there being complacent about certain things, you're not open to different ideas and different things, and to learn better perhaps from other countries of how we did things. Perhaps a little bit more openness or transparency from countries who perhaps had a jump start on this issue could have assisted us in perhaps learning a little bit more and doing things a little better as they came through. It's almost seemed like we were kind of going through this all by ourselves. But it's unfortunate because, some other countries were 2, 3, 4 weeks ahead of us. So perhaps disseminating some information over to the medical side to understand this problem, the immense or the complexity of this issue could have perhaps assisted us, and perhaps assisted us from not making the same mistakes. We've learned so much from when we started, and how we've evolved and how things have changed. So perhaps, having that information, but then, you can't play it's Monday night quarterback, because a lot of this is, you really can't, because this is a novel virus. And we're all going through this together as a global community. We are all being affected by this. So perhaps now is a chance to use what we've learned to perhaps teach others or to do better next time around, because I do see this virus having reemerging itself, or this particular virus or other viruses, because in the realm of infectious disease, we've done a lot of work, but there's still a lot of work to be done. So when it's great to have people, young people such as yourself, wanting to know about more of these, because I think part of that is as a healthcare system, we've done a great job with chronic care and other diseases, but perhaps because we're not perhaps a tropical country or countries that are used to having a lot of virology or bacterial diseases, or like what they call a third world country diseases like malaria. We're not exposed to a lot of this stuff, and we're not exposed to having public health emergencies such as this. But it's almost like a wake-up call to realize that it will hit our shores. It's not something that you're immune for. When the whole thing started and we saw China and Italy having this, there was a sense of that it's not coming to our shores, and it did. So with the global travel, with the fact that we are now so connected, things that happen in remote areas like Wuhan, China, in a little city, all across the other side of the globe can have a great impact on the rest of the world. So, we can't be complacent about things when things appear, and we have to do a better job.
Yeah.
Definitely. I think it's definitely going to set a precedent moving forward for how we react to certain things.
Yeah. And then if you had been given significant warning about the pandemic, how would you prepare differently? And how would you handle it differently?
I think from the acute care side, as we're handling issues and we have learned about things, I think perhaps what we could have done better was preparing ourselves with, having enough protective gear and equipment for our employees. I think part of that was we thought we had enough, but the immense amount of the incidence and the prevalence of this disease, and it came with us with such force that we weren't prepared. So we didn't have enough protective equipment for our staff we had to look forward to the government, and the government wasn't prepared. We didn't have enough ventilators. We did not have enough equipment like monitoring equipment. We didn't have acute care, like intensive care services, because we didn't foresee or perhaps look at the fact that these patients get so sick so fast, and they require such intensive care services that even from a human resources perspective, like we didn't have enough critical care doctors, we didn't have enough critical care nurses and healthcare to deal with such complex problems that these patients have. So a lot of us did the best that we could with the situation, but knowing that and what we've learned, I think perhaps moving forward, if there is a second wave to come, and it's not an if, it's a when, but hopefully we will be able to contain a little bit better. We'll have better testing capabilities. Perhaps we will test our patients faster. Perhaps we will make sure that we are isolating some of the patients earlier on. We're testing our employees, making sure that they're also negative, because our employees can be also, like healthcare workers, can also carry the disease and infect our patients as well. So we have to be very careful on both sides. So it's not just the patients, but also the employees, that we're making sure that we're not transmitting diseases. At the end of the day, it's about basic hand hygiene and making sure you're, covering your hand, nose and mouth, because that's where the droplets are going up in the air and might stay. So part of this is basic infection control practices that perhaps we weren't doing a good job with, and perhaps we need to make sure that we're ironing it out even now.
Right.
Could I ask a quick follow-up question?
Yeah.
So do you think if supplies had been dispersed or decimated significantly earlier than they had, it would have been easier to maximize resources and the physical space of of a hospital?
I mean, the immense surge, we saw surge, right? So it almost seemed like it was a burst of surges of patients coming through the hospital, and the hospital itself did not have the capacity. Hence, the government looked to opening up other sites, like the Joppa Center, and we had, say, the Secaucus site in New Jersey that we had to open up, and not enough resources within the hospital to take care of such complex patients. So it almost seemed like we were converting other units into an ICU. And so could we have done this better? I'm not sure. I don't know if in normal cases, scenarios, do we apply the norm to a surge and the complexity of this pandemic? We can't. So we have to do the best that we can, but when it goes back, it's not realistic to assume that we'll have the same number of, say, human resources or capabilities. So do we need the same amount of critical care doctors and nurses in normal times? No, we don't, because we see that as the numbers go down, we may not need it, but during that time, we needed it.
Yeah.
So, it could have where perhaps what we could think of is, as countries like New York did, the governor. What he did was he tried to mobilize it from different hospitals. He tried to move resources, people from different hospitals that perhaps weren't experiencing the same type of complexity and the surge and the pandemic to hospitals perhaps that needed it most in the city. So deploying resources, right? Deploying people, deploying PPE. I mean, I don't think like as a country, we were prepared to handle the pandemic because we didn't have enough ventilators or we didn't have enough PPE, like personal protective equipment. I know the country's starting to shore up right now with more production because we anticipate the second wave, or, you know, when the flu season comes in, we will expect the same, you know, so we're trying to shore it up and making sure we have enough, but it's still not enough. You know, as we say, we're still not there. Even now, because if you tell me right now things are getting better, well, the numbers of COVID patients have gone down, but we're still experiencing a scarcity of personal protective equipment. We're still we're following CDC guidelines on how to extend the use of a gown or how to extend the use of an N95. In normal circumstances, it's a one-time use. But now we've been told by the CDC that if you're assuming having a shortage, you can wear it up to 12 hours like an N95, or you have to wear it like for, you know, 5 times or use. So, and the gowns we've been trying to reuse. So things that we perhaps in normal circumstances didn't go through, we had to go through during the pandemic.
Right.
Definitely, definitely. So maybe if possible, could you please describe a little bit about the healthcare system? And then now that you've experienced this pandemic firsthand, what new takeaways do you have about the system?
I think as the American public health system, for example, has always had the goal to kind of have both, you know, you have to reach the triple aim, and we're not there yet, which is, you know, you have the aim to have equity in healthcare. It's not there. So we have to realize equity in healthcare comes from the fact that the same amount of resources are given to everybody, right?
Yeah.
The fact that you have to make sure that it's accessible to all people, where we have learned that a lot of people who are of the minority groups have experiences greater depth and morbidity and mortality in these cases. That's because, you know, we're starting to understand we have to try and acknowledge that there is what they call social determinants of health and well-being. Health and well-being is not just because you have a physical ailment. Health and wellness is because it's an all-encompassing kind of idea or a model, where it also depends on the fact that if you have a good socioeconomic status, you have greater access to healthcare. If you have good socioeconomic status, you have greater access to nutrition, better healthcare visits to your doctors. You're able to control medications, for example. You're able to control a lot of comorbid conditions. The reason why you had a certain set of populations dying at a higher rate is because they didn't have all of this. So when you're asking someone to quarantine themselves in a multifamily home where perhaps they don't have access to good health care, for example, your homeless population, there were quite a bit that was affected. We couldn't really control that because we tried as a healthcare system to do better, but we couldn't. We failed in a lot of these populations that are vulnerable because we did not realize it's not just about getting them to a hospital, but it's also the fact that we have to ensure that they have shelter, that they have adequate, nutrition, that they have adequate primary care visits. So a lot of this has, as an American healthcare system, we have to work and do better this time around. And hopefully this is our learning lesson moving forward, because it's not in silos. Things don't work in silos. It's all interrelated.
Yeah.
Definitely.
I mean, did you find that there was a surge of cases in the homeless population or minority groups compared to other groups?
I think At first we tried to see a little bit, that, but not as much because we early on, I think the city of Hoboken and I guess the county did experience issues with homelessness, and have always had issues with homelessness. But part of that was, how do you make sure that they don't go out and infect others? So once they came into our buildings, into our facility, for the most part, we had to keep them. So we couldn't discharge them. So a lot of these patient populations, for example, the nursing home populations, so you've heard a lot about how the nursing homes got hit and where they're frail. At first we were told we couldn't send them back because they didn't have the facility or the resources to isolate their patients. They had a lot of employees going in and out. They were working 2 jobs, or they were going from one facility to the other, and ended up infecting the patients in the nursing homes. And once we did get some of these patients in, it was kind of hard because we needed, we had to keep them. But unfortunately, what happened was there were more patients that were coming in. We couldn't deny it. And so you had either a homeless population or like the elderly frail that was holding on to a bed, that perhaps there were so many others that coming through the ED that required the bed. So it almost seemed like within our hospital, we had to triage. We had to say who needed the most resources. So if you had patients who were, having a lot of intensive care resources, we had to put them there, and we had to find other means. So that I think the city and eventually the state started opening up other sites to help assist move these patients out as they were getting better. They weren't fully well, they were still sick, but you have to realize we had very, very sick patients that perhaps needed the most. So when you look at a public health emergency, so it's almost like we have to say, who needs our help the most? And in those pandemic, you had to go to the ones that needed the help the most. And you had to kind of, I wouldn't say ration, but you almost had to do that in order to say, okay, now you are almost better. Maybe we need to find you a different space because somebody sick needs this bed.
Yeah. Wow.
That's crazy. So after living at the epicenter of a pandemic, how do you think the healthcare industry will change?
I think a lot has changed in the healthcare industry. I think a lot of innovation has come through. So let me just start by saying some great things about how innovation, out of a lot of this came in telemedicine, the use of technology to kind of assist with well-care visits. So a lot of physicians in their offices who were actually having patients previous to the pandemic having come through, in their office visits, were able to kind of make air visits, through technology and kind of look at their patients. Of course, certain patients, it's not the be all and end all, but I think for the majority, they were able to do a lot of visits. They were able to see their patients, make some diagnosis, and also assist them with, some of the issues that they have, refilling their medications, for example. So that, perhaps could be, I would say, is some of those great features that perhaps would continue going forward. So use of technology to get a lot of specialists, and you can do it, the physician offices can do it. So if you think about having a lot of the infrastructure, doctors' offices, having a full-blown office staff, and a lot of the stuff can perhaps, I do feel like that's going to change a little bit. And what is also perhaps going to change is trying to use of technology, for example, in the hospital itself. We had to use a lot of technology solutions, a lot of innovation to help with our patients. We had to use, for example, cameras. There are certain times we would try to minimize exposure going into the room. So we installed the small, it was a very simple idea to put camera devices in the room so we could monitor our patients who were really, really sick, and at the same time reduce the number of exposures for our staff going in and out of the room because these patients were so sick. So a lot of things that we did, out of the norm and out of the box, things that perhaps in normal circumstances we wouldn't be able to do, because you're just taught a certain way and you keep going a certain way. But this pandemic surely taught us that it's time to start thinking outside the box a little bit, and trying to use perhaps I do think technology as one of the biggest feature to kind of use that to move the healthcare industry, who perhaps, in my estimation, has been a little lagging behind in doing a lot of out-of-box thinking for our patients.
Yeah, I definitely think like advancements in patient care efficiency is something, in terms of electronic visits and like Zoom calls, is something that is really new.
Yeah, and we had a lot of patients in themselves who we connected with. Unfortunately, the human connection is still a great thing that we cannot take away from what we do every day. What we did see was we got in about 20 or 30 iPads on stands, and then we use that to our patients when they're wanting to connect with their families. So we kept connecting, wanting to make sure that the human connection, that relationship was there and it was ongoing with their family members, that they never felt that they were going through this alone. Initially, looking forward and say, what would I have done better? I think part of that was we got so caught up in taking care of them that perhaps we didn't realize till a lot of patients were dying by themselves. They were dying alone. They didn't have family members close to them while this was going on. So for the most part, then we started deploying other people just to do FaceTime. We just made sure some of the nurses, just made sure that they would go around. Of course, we needed nurses and doctors to do a lot of caring, but there were certain nurses and other employees, maybe we shifted other people from other places to do different things. I do have to say one great thing is with this, everybody came together, all the nurses and their doctors were saying, how can I help? How can I do, even though it wasn't their specialty, it wasn't their skill set, they wanted to help, and they helped tremendously, because people, pediatric nurses are not used to taking care of adult patients, stepped in and helped to get, there were patients who were in the nurses, we shut down our ORs and our post-anesthesia care. They had different things that they used, we deployed them for other resources. So everybody in the hospital was doing something. We had people, security people, human people who worked desk jobs. Our human resource director was helping us move, not to be morbid, but there was a lot of patients dying, and we had to move patients into out of the morgue and into freezer trucks, and we have freezer trucks outside. So that we are, I know it's kind of harsh when you hear things like that, but that's what the reality of the pandemic was. We were having a lot of deaths on our hands, and we had to deploy resources. We had to use unconventional means in order to, safely care for some of our patients, as well as how to handle death and respect the dead. So, we had to use some of the people who are not used to doing these things, handle such things, So a lot of people came together in so many different ways. There were areas that were shut down. For example, we weren't seeing patients we have clinics outside the hospitals. The clinics weren't seeing patients. So they got deployed and into the hospital, even just passing the iPads, for example, or helping a nurse, or taking a specimen down to the lab, so it was almost like we had to use a command. So my job basically was, let's look at all these people in the hospital and how best can we use them to address the pandemic. They might not have a skill set, but their skill set is just as important, and how can we transfer that skill set to assist somebody with patient care. So team nursing, for example, was deployed. Yes, we didn't have a lot of critical care nurses. So we employed one head critical care nurse, and they had somebody who was less skilled, maybe not as critical care, maybe another nurse from another area who perhaps didn't know, but can assist the nurse,
Yeah.
and another aide, so like it was a team-based approach to helping, because when the pandemic hit and there were so many patients and so few of us, we had to use the best way to kind of manage our patients.
Yeah.
Definitely.
I mean, going back to what you said about the ventilators and hospital beds, did you find that you were in like a situation that New York was where you're going to run out of ventilators or run out of hospital beds?
Yeah, I mean, thankfully, we had enough. So what we've learned over, if you could go back and say, initially when we all started with this pandemic, what we were starting to learn was, let's intubate them early on. Let's intubate most of our patients
heard about
early
that.
on. And maybe that will save the life. What we found out is once they got intubated and they stayed longer than 10, their mortality rate went up really, really high, because this disease just baffled a lot of critical care physicians, a lot of physicians and nurses, on how complex this disease was and how it appeared or manifested itself. So early on, what we learned was, let's do this. But part of that is now we're learning is maybe we shouldn't have ventilated these patients. Maybe we should have waited a little longer. We should have tried different medication, but we didn't have those set of cocktails, right? We tried everything. It's almost like you threw the kitchen sink at them and kind of said, let's try this and let's try this, and maybe this will work, and maybe that will work, and let's hope each patient was responding differently to different treatments. Of course, we did have a lot of success stories. I'm not saying it was all bleak. We did have patients that were discharged, and we were starting to, early on, we got caught up in how many people were dying. But then later, for emotional well-being, not only for our patients and our staff, because the patients themselves sitting in these rooms are hearing code blues called, and code blues are like, response teams to somebody who's having lost their pulses or needs respiratory assistance. So when you start to hear a lot of this, it kind of times three all going at the same time, when it was happening, like 18, 20 a day, it kind of numbs the spirit just to hear such bad news. And then we had to shift our thinking to kind of say, every time a patient's being discharged, let's celebrate that as well, because it's not right to just hear something. Maybe some, emotionally, patients will feel better once you hear the fact that we are doing better, we are discharging patients. So we had to change the paradigm from how many deaths we had to kind of put posters around the hospital and say, we've had so many patients being discharged. So every time a patient would get discharged, we would play a great song on overhead, and that kind of uplifted. Because, in our labor and delivery, whenever a baby is born, we have a nice chime, right? So it was along the same line. So we started to play a victory song every time, and we would say this is in recognition of all because they're fighting too, right? It's a battle against death. It's a battle to get better. So emotionally, the patients need to hear something very, very upbeat on the fact that there are patients that are doing well. They're going home. They're feeling better. So we had to change that a little bit. Like I said, as we went through it, we learned better other things that we could have done better, and this was one of it.
That's great. That's great. And our final question is, how do you think society is going to respond when everything starts to reopen again, in terms of like precautionary measures as well as other aspects?
I hope common sense and better judgment prevail for a lot. And I do understand the public sense where if you're not used to staying home, and this can get to you, the loneliness can get to you, the fact that you're being quarantined can get to you. But I hope and I implore that we continue, we realize that there's a lot of asymptomatic patients out there. So
Yeah.
positives out there. So this disease hasn't left us. It's almost like it hasn't left us, because we do see what we're seeing in the hospitals is patients who've had infected. So we assume that once you get infected, you're not going to get the disease again. We're starting to see that. So, I mean, there's a lot of assumptions with previous other virology and disease presentations. Perhaps doesn't apply to this disease. So we have to be cognizant that, droplet, for example, this is 6 feet. Oh, it's not 6 feet, it's a little longer. Or, it used to be just 5 minutes or 6 minutes, it stays in the air. Now it's a little longer, So a lot of things that we don't know about.
Yeah.
Right. And so we still have to be careful. So hopefully better judgment, people are careful, they clean. For example, hand washing is perhaps one of the most basic things in reducing the spread of infections. Sometimes you just have to go back to the basics, be a little bit more careful.
Yeah.
Don't rush out of the house without a mask, or, not having a hand sanitizer or clean way to clean your hands. Basic stuff. Go to the bathroom, clean your hands.
Yeah.
Definitely.
Yeah. Well, thank you so much, Dr. Philip. Thank you for your time. We really appreciate you taking the time out of your schedule to inform us and our listeners, and thank you for your service and everything. If you guys have any suggestions on what you want next as a topic for Meg and I to discuss, let us know in the comments below, or email us at megishan@gmail.com.
Yes, thank you so much, Dr. Philip. We hope everyone is staying safe and healthy, and stay tuned for our next podcast. Thanks for listening to our first episode.
Thank you. Awesome job, guys.